is Kami Parsa. I'm an oculoplastic surgeon in Beverly Hills, California. I've been asked to give a talk on a topic of lower eyelid blepharoplasty and how we can avoid some of the pitfalls and complications that are associated with it. So, if the lower eyelid blepharoplasty is properly performed, it can significantly rejuvenate the appearance of the face. And as you know, the lower eyelids are one of the first places that people see, and a properly performed procedure makes a significant difference on the appearance of these patients. Typically, it's one of the first things that goes through the aging process, and I think really the key on the newer techniques rely on minimalism, and as you see, identifying what patients would be the perfect patients for these things. Now, complications that are associated with lower eyelid blepharoplasty can significantly affect the quality of life. I can tell you that today about 60% of my practice has become revisional surgery, and we have patients from all over the world who come in that need revisional surgeries. So we have a collection of experiences on different ways that these complications can occur. And hopefully by the end of this talk you'll be able to understand the process involved in avoiding some of these complications. And at the end of the talk we'll talk about how we can treat some of these complications. So now, most of the time complications happen because there's a lack of communication between the doctor and the patient. And I think this is probably one of the most important things that happens. So it's really important to listen to the patient and see what the patient wants and be able to match what those desires are. And if there is a discrepancy between this communication, that's the first thing that starts falling down a wrong path. Also, in your assessment during the evaluation part of the exam, you need to look for some of the red signs, which we will talk about. And if you're able to identify some of these red signs, then you will modify your technique to address those things. Now, I think another reason for having complications is that most of the surgeons that operate around the eye don't have a lot of understanding of the delicate eyelid anatomy. As you know, the eyelid anatomy is significantly different than anywhere else in the body, and you need to have a good control and understanding of how it interrelates with each other, and how that understanding can help you prevent some of the issues that happen. Another thing is a cookie cutter technique. Some doctors just know one way or two ways or maybe three ways of doing lower eyelid blepharoplasty, and thus they use that technique on everybody. And that becomes an issue, because if you use the same technique on everyone, sooner or later somebody's anatomy is going to be different and you're going to get into trouble with that. Another issue that's important is that a lot of the older techniques that are out there are very aggressive, and some people are very aggressive intraoperatively, and that leads to some of the complications, as you will see. So now, what are these complications? The most common complication is dry eyes, and associated with that is also epiphora. So tearing is another thing that happens with these patients. Chemosis is another one that's usually associated with exposure and the dry eye issues, and we will talk about how we treat these. Ectropion is another complication that happens. This is a lady I saw from Texas that had her surgery done in Dallas by a prominent plastic surgeon. Again, aggressive intraoperative techniques, and I think really lack of respect for the normal tissue in that area led to some of the things that we see here. Again, so as you see, this patient does have lower eyelid retraction. Again, eyelid retraction on someone who has a negative vector, and a cookie cutter technique was used that led to a lower eyelid retraction complication. Another complication we see is the canthal dystopia. So presence of canthal dystopia is something that is the U-shaped deformity that a lot of people talk about when someone is very aggressive in skin removal and they don't anchor the canthus, so there's a U-shaped deformity at the canthal corners and the patient just complains of not looking like they ever did and they don't look natural. Eyelid asymmetry is another thing. This is a patient that had a procedure done again by an outside surgeon. As you see, there's really no, in terms of placement of the incision lines, placement of different things, the patient has eyelid asymmetry. And last but not least, blindness is one of the risk factors and complications that can occur. So what are the risk factors for dry eyes? If somebody has a history of dry eyes, you need to know about this. So that's why any patient that comes to our center, we ask them, part of the initial exam, do you have a history of dry eyes? And that really determines on how your approach is going to be with these patients. Sometimes if a patient has severe dry eyes, I just refuse to operate on them. So that really weeds out a lot of patients that could have potential problems after surgery. History of refractive surgery or corneal surgery is also, these days a lot of people have the LASIK procedure, and that can lead to dry eye issues. Blepharitis is another common thing. That's why every patient that we see does get a slit lamp examination. It's inflammation of the eyelid, and usually because the meibomian glands are not secreting some of the oily part of the tear film, these patients are prone to having dry eye issues. Lag of thalamus and poor Bell's phenomenon. This patient does have Graves' ophthalmopathy, which is also a risk factor, and thus prominent eyes. And as you see, if you do a lower eyelid blepharoplasty, that's a cookie cutter technique on this patient, he's going to have significant amount of issues postoperatively. And prominent eyes are other risks. So every patient that comes in, the first thing, as I mentioned, we ask them if they have dry eye syndrome. Now, during the exam, I do some assessment as well. We look for blepharitis if they have under slit lamp. If they do have blepharitis, if they have conjunctival injections, typically I ask them, why are your eyes red? It could be related to contact lens use or just poor tear production. We also look for tear breakup time, which is typically less than 10 seconds. And the way you test for that is you look under the slit lamp, you have the patient blink once, and you see how fast it takes for the tear film to break. Woods lamp or slit lamp examination again is important in assessing these patients. Schirmer 1 test with anesthetic could be incorporated. I only do it on patients who give me a history that they have dry eyes. Again, we're starting a trend, and this is not really the gold standard of how it should be assessed preoperatively. Corneal sensation is also reduced on some of these patients. This is part of the Schirmer exam. You place the strip in there, and after 5 minutes you assess to see how much tear is produced. A normal result would be more than 10 millimeters with anesthetic, which is proparacaine or tetracaine. Now, what are the risk factors for chemosis? Exposure and desiccation is one of the things. So typically, if I see any chemosis, you want to see that why is this happening, and it happens when the conjunctiva gets irritated, and the reason conjunctiva gets irritated is because of exposure problems. So treatment for that will have to somehow incorporate addressing this dry eye issue and this exposure issue. If someone had a lag of thalamus that wasn't addressed, if somebody had multiple procedures at the same time, you can develop chemosis with it. Or if somebody had a volume overload, they also could have that. So how do you treat the chemosis? typically on all my blepharoplasty patients, I just give them artificial tears from the beginning. So we instruct them, get artificial tears, typically the ones without any preservatives, so non-preservative artificial tears, and you use that 3 to 4 times a day on a regular basis, starting from the first day after surgery. And during surgery, again, my newer techniques are very minimalist. I don't even, my lower eyelid blepharoplasty is done with a 5mm incision on a transconjunctival approach, and it doesn't require any sutures or anything, and it makes a huge difference on that. So you can patch the patient if the patient has chemosis. I typically patch them at night when they go to sleep if they have chemosis. You can also start them on a variety of mild steroid drops like Flarex, FML, Alerex. These are all just commonly used steroid drops twice a day for a week that I have them on if they develop this. And if there's persistent chemosis, you could do a conjunctivectomy or a Tenon's capsulectomy. But you know, I rarely see these kind of complications that need this type of aggressive treatment. Now, lower eyelid retraction and ectropion, again, is an unfortunate complication of a lower eyelid blepharoplasty. This is a patient that had her lower eyelids done by a prominent plastic surgeon in Beverly Hills, and because of extensive dissection and part of the post-operative complications, she did develop significant amount of left-sided lower eyelid retraction. Obviously, it's aesthetically it's unacceptable, and functionally and can be really disabling because these patients can't close their eyes and they have significant amount of problems with it. So in order to understand why we have eyelid retraction happen, and I think this is really fundamental. If there was a slide in this talk that I would want everyone to understand, it's this one. The eyelid structural support is really key in understanding this. There are 2 elements to it. One is a bolster support, which we'll talk about, and one is a tensile support. So when we talk about the tensile support of an eyelid, it has to do with the tarsoligamentous sling, which is starting from the lateral canthus, is the lateral canthus, the tarsus, and the medial canthus. And as far as the medial canthus is the posterior cruciate, which is the most important part. Again, this is the backbone and the tensile support of the eyelid. Also, for the tensile support is the orbicularis oculi tone. And as you see, the orbicularis oculi is a muscle that closes the eye, and it's just normal tone. It pulls the eyelid up, and the lack of any tone, as we see on some of the patients who have facial paralysis, leads to eyelid retraction and ectropion. So the second thing is the bolster support of the lower eyelid, and for one thing is the malar soft tissue itself, so the mid-face tissue, the negative maxillary vector. As we age, we start losing bone volume, and the maxilla retracts backwards. Not only that, but we do lose soft tissue, and that significantly decreases the bolster support from these supporting elements. The lower eyelid fat pads, as you will see, play also an important role. And again, traditionally the lower eyelid fat pads were removed aggressively, and I think that aggressive removal leads to lower eyelid retraction. And the key, as I mentioned, the newer techniques we have, we don't really remove much of a fat. We either transpose it or contour it with just minimal incisions, and it really gives a natural look to the eye, the appearance of the eye, and the patient just heals much faster, and that I think is going to be the norm in the future. And so all of these components give the bolster support to the lower eyelid. Just to mention the lower eyelid fat pad, as I mentioned, its position is dynamic, and it depends on the gaze. In down gaze, fat is retracted posteriorly, as you see, and it allows the eyelid to kind of buckle inferiorly. And if you're very aggressive with fat removal, you're going to lead to problems with bolster support and thus lower eyelid retraction. So this is a patient who had over exuberant fat excision, and as you see, that bolster support is gone, and the patient has lower eyelid retraction bilaterally and canthal dystopia, and she's not really happy with how her eyes look. Again, this is a patient that has seen me for a revisional surgery, and we're planning on fixing this at some time in the future. But there are some red signs that should automatically make you stop and say, is this patient at risk for having complications? Number one, and number two is this patient going to have issues? So the key is to understand the anatomy, understand what are the bolster and tensile support factors, and then you step back and say, are these in line with some of the risk factors? So patients who have proptosis, very prominent eyes, are at risk, because when you remove do any lower eyelid surgery on them, the weight of the eyeball is sitting on it, and it's going to cause retraction and cause issues. So anytime there is a patient who has prominent eyes or a negative maxillary vector, we do address the lateral canthus at the same time. So as I mentioned, the maxilla, normally on patients who have negative vector, their eyeball is sitting ahead of it, and if you draw a straight line out, these are patients who have negative maxillary vector and can have complications associated with lower eyelid blepharoplasty. Again, horizontal eyelid laxity needs to be addressed with it. This is an older gentleman who had significant amount of laxity in upper and lower eyelid. It's actually a patient with floppy eyelid syndrome that a standard cookie cutter lower eyelid blepharoplasty or upper eyelid blepharoplasty does not address any of the complaints that this patient has, and those things need to be addressed with. I said another thing that we talked about was orbicularis palsy. As you see, this patient has right-sided facial paralysis. The brow is ptotic, the lower eyelid is ectropic, it has ectropion and is fallen. And this is a patient smiling, and as you see, he can't smile on this right side of the face. These patients, again, they're at risk for having complications, and you need to address the tensile support element on this while you're operating on them. Another thing that we've noticed is that tall individuals are at risk for having issues, because these people are walking around. This is a patient that we saw that was over 6'8", and he's looking around constantly at the world in a downward gaze. And postoperatively, he's developed lower eyelid retraction, and as you see, the indentation here is because his eyeball is looking down constantly, and it's kind of pushing and leading to some of the problems that we see. So this is him after we did a revisional surgery on him. As you see, we addressed a lot of the complaints he had, and a lot of those things have been addressed by these procedures. So what are some of the intraoperative issues that I see? I think subciliary incision and extensive skin muscle flaps are things of 1990s and before. We don't do those kind of surgeries anymore, as I mentioned. Typically on 98-99% of my cases, I do a transconjunctival approach, which really addresses all the issues. The patient heals much faster, and it's just a more natural, beautiful result instead of an aggressive movement such as a subciliary incision. Aggressive skin and fat resection, again, we don't do, so I don't recommend doing that. And I think we're going to see a trend in the future away from any kind of fat resection, and you'll see some of the newer techniques that we're doing involve really just fat contouring, which makes a big difference. And there are surgeons that use septal plication or septal reset, and I can tell you that if this could work on a certain percentage of patients, but if you're using this technique on everyone that walks in the room, you can have sooner or later get into trouble with this issue. Now, some of the techniques, again, most of the techniques on fixing these problems and these complications it involve addressing the tensile strength and the bolster strength. If you didn't understand this, I would really recommend opening up an anatomy book and really going over some of these concepts we just talked about. Again, the key involves a lot of people do mid-face advancement, and most of these techniques again involve bolster and tensile support. So this is a paper that was done by Munjal Patel. Again, they do advocate the use of hard palatal graft and addressing the lateral canthus and the mid-face at the same time, which is typically what I do as a gold standard for patients who have severe retraction, and I think it works beautifully. Now you have multiple options for your posterior spacer. You can use a hard palatal graft. You can use Endorogen, alloderm. Hard palatal graft is probably the best option for patients who have severe retraction because it's autologous tissue. And use of dermis fat grafting, Bobby Korn and Don Kikawa in San Diego this is a paper they published. I personally think there is a role in this, but not on every patient. Certain patients who have very poor bolster support, such as negative vector patients, would benefit from this, or who have prominent eyes. I wouldn't use this as a standard technique on every patient. Again, it utilizes some of the ideas we talked about in terms of bolster and tensile support. Robert Goldberg in UCLA has talked about use of hyaluronic acids, and I think it's actually one of my favorite things on an early period when somebody shows up that has had is about 2-3 weeks post-op, and they see you for consultation. You can in office put something that do something that makes a difference. And the way it works is you go on a suborbicularis fascial plane and inject it in that area, and the idea is it does disperse some of the inflammatory components that come in play, and it also plays a role as to bolster the eye by its fluid gathering process. Also, Goldberg talks about use of orbital rim onlay implants. Again, it's good for certain patients who have prominent eyes. I wouldn't use this as a standard technique for everyone, and I personally believe that hard palatal grafts are still one of the best options out there. So again, everything we just talked about utilizes the bolster and tensile support to correct these issues. And if you understand these concepts, you can do a lot of good revisional surgery on these patients. So now, one of the other things that we've started to do is use steroid and 5-FU. This is a patient I showed you that had surgery by a plastic surgeon in town, and I started injecting 5-FU and Kenalog 10, and as you see, the eyelid retraction that you see was resolved after 2 to 3 months without the use of any surgery. I think just massaging it and injecting on a regular basis. I see them every 2 to 3 weeks, and we assess to see how it is. Typically, you don't need more than 0.1 cc, 0.1 or 2.3 cc's injected. So key in preventing any complications, obviously listen and respect your patient. If this element is going to be very essential, I think it's one of the most important parts of my practice, and you really need to respect that trust that these patients have with you, and it becomes in a way a spiritual journey with that, and it really helps you in preventing a lot of things that happen. Chemosis and irritation again can be resolved. They can happen. common complications, but you need to understand the process involved and address them as we talked about. Be very conservative on patients who have poor tensile and bolster support, and because they can have a predisposition to ectropion and eyelid retraction. Again, also be conservative on those patients who have dry eye issues, because they can develop secondary dry eye problems. And most importantly, incorporate steps in your evaluation and ID these pitfalls before they happen. I hope this was helpful. If you have any questions and you need more help on these topics, please feel free to call my office. Thank you very much.